In today's video, we're going to be giving you an overview of the science of cancer. You had a lot of detailed reading on the matter that I suggested a more skimming style approach to. Hopefully that skimming gave you a bit of an appreciation for the complexity. Basically, any one topic in any of these readings is a whole body of scientific literature. If you have a friend, parent, or other loved one currently or previously diagnosed with cancer, I might suggest spending a bit of time this week reading some literature about the particulars of their treatment or case. Feel free to ask questions about it, and we can help you work through the literature. In this video, we're going to start by talking about apoptosis, the lack of which is the fundamental cause of cancer, and then move on to risk factors and treatment. Apoptosis is often called programmed cell death, but personally I like the phrase highly regulated a bit better. There are so many genes and therefore proteins which control this. There are many redundancies and checkpoints built in to ensure it happens, and it's incredibly important. These pictures walk us through what happens. Wikipedia's entry on this is actually really good if you'd like a more in-depth set of pictures. I tried to pick one that was appropriate to this class's interests and audience. However, if you are interested in cell biology or other topics, stop by that entry to look into it a bit more. This needs to be at exactly the right amount. If you get too much apoptosis, that causes atrophy. Too little, then you have cancer. So of course, that's what we're going to be focusing on today. The basic idea is that at some point, for a myriad of reasons that we'll mention in a moment, cells are tagged for apoptosis. When this happens, the membranes start to get these irregularly shaped areas that are called blebs, and the nucleus starts to break apart. The blebs become larger and larger until they form these membrane protrusions. There are some variations based on the cell on which types and how many of them are formed. From there, the cell breaks apart. You'll notice in the picture that these pieces seem to be encapsulated. Those are called vesicles, in the very general sense of an area surrounded by a membrane. And then more specifically for this specific case, they're called apoptotic bodies. These pieces of dead cell can then be cleaned up by the body's various janitors. The membranes surrounding the components of the cell allow it to be taken into white blood cells, and this is called phagocytosis. Hopefully, you remember a bit about the cell cycle from the bio classes way back when. If not, that's okay. The overview is that after a cell splits, it undergoes a growth phase, then replicates its DNA, has another growth phase, and then undergoes mitosis for most cells. Mitosis then has several steps as the DNA comes together into chromosome, lines up along the center of the cell, and is then pulled to opposite ends where it can divide and start the whole cycle again. This is, of course, a dramatic oversimplification of the complex array of proteins that are coming together. At each point in the cell cycle, there are checkpoints that occur, which will induce apoptosis if a problem with one cell is detected. This has a lot of redundancy built in. Our body undergoes a lot of mutations, and you are unlikely to find anyone that doesn't have at least some risk factor, genetic or otherwise, for cancer. Without these redundancies, ensuring that any one problem wouldn't cause us to get cancer, we'd be in a lot of trouble as a species. You can certainly look up all of these details on exactly what they are, and you may hear about a particular gene causing a problem in a particular phase checkpoint. But this starts to get pretty far into the molecular biology weeds, and I don't really want us to collectively go there. Going back to our quote on the first slide, this particular nurse said, "Cancer cells are those who have forgotten how to die." I was so struck by this statement. All right, so what was that quote saying? What this is saying is that if, for whatever myriad of reasons that can occur, the cell is able to elude all of the triggers and the signals for apoptosis, then it will just continue to divide and very likely can create problems. It also points out that this was and is a human cell. Though there are infectious agents which can cause cancer, they themselves are not the cancer. They cause genetic mutations in the cell, which then dysregulate apoptosis, causing cancer. There are a lot of ways that this dysregulation can happen, and that's one of the tricky parts about cancer. It's not one disease, it's a whole family of diseases that can all have all be very different from each other. This chart is another FYI, don't memorize, molecular biostyle chart that talks about several of the major ways that apoptosis can be disrupted. We're going to step back and talk about why these occur in a more general format. There are checkpoints in both of the growth phase of the cell cycle, which look through the DNA for any damage and try to repair it. If this cannot be repaired, it can tag that cell for destruction. There is another main checkpoint during mitosis. If the spindle fibers are unable to attach due to damage, then the cell gets stuck in metaphase until the issue can either be fixed or apoptosis occurs. These checkpoints, like basically everything in the cell, are really complex. There are many proteins involved, and remember that proteins are synthesized from our genes. So if you have a particular genetic mutation or mutations which cause the proteins involved in checkpoints to be less functional, that becomes a genetic marker for cancer. Generally, one gene alone isn't going to be enough to cause this, but it is an increased risk factor. There are two main groups of genes that can be markers for cancers. The first are called tumor suppressor genes. You can think of these like brakes on a car. When you hit the brake, the car slows. The proteins that these genes code for slow down the abnormal division, just like brakes slow down a car. If you mutate these genes in a way where they lose function, then the abnormal cell division can go unchecked. Just like if you lose brakes on your car, you can't stop the car if you're careening down a hill. The other issue that can happen is the mutation of what are called protooncogenes into oncogenes. These are like the gas pedal of the car. They tell the cell to divide, which is necessary and a good thing. However, just like you need your gas pedal, you don't want it to get stuck. If your gas pedal gets stuck on, the car careens out of control. Similarly, if a proto-oncogene is mutated, the cell divides out of control, causing cancer. So before moving on, take a moment and think about the risk factors that you know of for cancer. Try to also connect why these risk factors exist, given the information that we just talked about. Come back after a few minutes and then listen to me talk about them. One of the absolute biggest for most cancers is age. There are a few exceptions that happen to young children, but generally, as you increase in age, your risk increases. And if we think about the fact that there are redundancies in our checkpoints for cancer, this makes sense. Any single mutation is usually not enough to cause cancer. But as we get older and older, our cells pick up more and more mutations. Eventually, enough mutations occur that this redundancy isn't enough, and the cell develops into cancer. Genetics are another big factor. There are a lot of genes that have checks and balances on cancer. Mutations in any of those that are inherited is one step closer to cancer. So some of these are bigger risk factors than others. The one that is most commonly discussed outside of medical areas are the BRCA genes, which are best known for their increasing in breast cancer, though they increase many other cancers as well. So this picture is, of course, not something that you should worry about memorizing or even really completely 100% understanding, but each little circle is a possible inherited risk factor, and this is a map of how they are related to each other. The take-home message being that this is really complicated, and we can stop there for the sake of this class. However, as always, I want to make sure that you have more resources if you want to go deeper into any topic for your own interests. So here's one reading that I thought was particularly good for walking through it in a pretty understandable way. It is about 15 years old, so it's getting pretty out of date, but it's a good starting point. We don't spend much time talking about these direct-to-consumer DNA tests in this class, so I thought maybe I'd mention them here. Under the Obama administration, laws were put into effect that prevented the company from releasing any information about genes that could cause the patient direct harm. So for instance, I could find out if I was a carrier for any gene that I might pass on to my children. And I could find out, for instance, the reason that I hate cilantro is because I have a gene that makes it taste bad. But I couldn't find out if I had the BRCA mutation or not. Since that rule was put into effect, companies have kind of gotten around it by providing education in the form of little online modules that teach people about what a genetic predisposition means. So pause the video and think about some of the reasons for this whole scenario playing out. Why was the law put into effect to begin with? And then why was this module idea put into effect? Do you think that the modules are good enough? Or do you think that in order to get this information that you should have to go into a geneticist or a doctor? Record your thoughts on the group activity form and talk about it with your group. I'll tell you my thoughts on it, and then in your groups you can talk about how this mismatched or matched up with yours, and if you'd want this information. So you may want to skip this next slide and come back to it after you've had a chance to talk about it in your groups. This is going to be the slide you want to skip if you want to talk about it in your groups, but I want to go ahead and just put it all in one video. So the idea behind this ruling is that this information is medical advice that shouldn't be used except with a doctor or genetic counselor helping to guide you or any individual receiving that news. And in theory, that's an excellent point. After all, not everyone is going to take a class like this to help them understand what that means. Next class, you're going to learn about how some people, in the cases of the BRCA gene, made really dramatic medical decisions based on just a gene or two. Personally, I'm a bit torn on this concept though, because the counterpoint is that many doctors do not do appropriate jobs of counseling anyways. So you're making people pay a really hefty fee to go through a medical professional without any guarantee that it will do anything but cost them 5 times as much. And I'm uncomfortable with the idea of only allowing rich people or well-insured people to know their genetic information. That being said, I got my raw genetic information and played around in a Gene Explorer window with it. My information was the absolute best that I could have possibly hoped for, and yet it was still pretty nerve-wracking because everyone has genes that increase risks for certain things. There are just so many there. There are just so many that there could be, that there just isn't any statistical way out of having some of them. And seeing how even a best case scenario, and being someone who understands how all of this works, and still seeing how that made me feel, I can't imagine being someone who doesn't understand how those statistics work and how those play out and what these risk factors mean, and then seeing all of this information. Over the years, I've had many friends and family members talk about perhaps wanting to do 23andMe and I'm in a position where I could actually help them analyze those raw reports that were given for their own genetic info. There are several of whom my offer was, I'm going to do it for them, and I'm going to give them a watered down summary to mitigate any of those concerns that they might have. And then there were many others who I basically just said, here, I'll set you up with it and I'll help you play with whatever you want to learn about yourself. And the fact that I wasn't actually willing to set this system up for any and all of my friends and family did give me pause as to why that rule may have been put into effect. So there's pluses and minuses to it. You're limiting access, especially access based on the monetary situation of the patient, but you may also be preventing them from making mistakes. So again, I have no exact answer on this so much as here are the pluses and minuses of it. So then here are the current compromise. The current compromise seems to be that the companies can release some of the more evidence-based simplistic information. So for instance, we know that the BRCA gene increases the risks. There's no doubt about that. While not releasing some of the more exploratory information. But they have to take a little online module to get this information released. So I went on and took it, even though I already knew my results from playing around with it on my own. I don't think it remotely does the situation justice. It's better than nothing, and it's likely just as good as they'd get in a standard doctor's office, but it isn't really the level needed to really understand the implications and get at the ideas that we're going to be talking about next class with Dr. Jenks. But I suppose just getting to likely as good as most doctor's offices is probably an appropriate level to allow it by the standard of typical medical treatment. All in all, it's really tough to say what the right answer for the whole country is. My personal values lie in open access to any information for those who want it, and I'd probably wind up coming down on the side of you give people the information that they ask for, and you do it in the way that allows for the widest accessibility and the most equitable accessibility possible. But it's really easy to see how others would come down on the side of protecting people from information that they might not know how to handle. Next up on our list of risk factors, we have the collective of environmental that I'm lumping together here. These can be carcinogens because the increase in DNA mutation rate or increase of replication rate of cells from coming in contact with it. So smoking, alcohol, a lot of pollutants are examples of chemical carcinogens. Of course, one of the biggest carcinogens is UV exposure. UV light is the correct energy to cause significant damage to our DNA. Of course, it only reaches our skin for the most part, so it's pretty limited in scope, but it is certainly quite an issue. Interestingly enough, this is often thought of as a sort of pale white person problem. And while people such as myself are certainly at high risk for getting cancer due to the melanin that we have, those with darker skin colors often have higher risks of metastasis and death. This is because even though their incidence of cancer may be lower, they aren't watching for it, and it isn't as easy to spot, leading them to seek treatment much later. So be sure that regardless of your skin tone, that you wear sunscreen and you cover up. If you are going to be in the sun for long periods of time, you really need to do this regardless of skin color. Radiation from other sources is also an issue. Generally, you don't need to be too concerned about an X-ray here or there, as most are relatively low radiation. But things like CT scans or radiation stress tests start to get significant, and you only want to get them if it's absolutely necessary. And of course, this comes up in cancer patients when they are getting radiation treatments. The treatment itself causes damage which can cause cancer. Another issue that comes into play is hormonal risk factors. These fall into general categories. They can come from external supplementation, largely called HRT, which is often a treatment for symptoms of menopause. And then they can also come from obesity. HRT is still often given to women, but more and more they are foregoing it due to the increased cancer risk and just having to deal with these horrible menopause symptoms. Obesity is often ignored as a risk factor for cancer since people tend to think of it more as a risk factor for heart issues. It is, of course, also a risk factor for heart problems due to generally leading to an increase in cholesterol and blood pressure, but it's a carcinogen too. Though the linkage between obesity and cancer has significant evidence for it, the exact mechanisms are trickier. I decided to stick it in the hormone section since many of the possible theories involve this. Obesity has a negative effect on insulin and other hormones, as well as many growth factors. So that's kind of where the hormone part comes in. Additionally, obesity does tend to cause a chronic low-level inflammation, which can cause a higher level of DNA damage than healthy weight peers. So this last mechanism is actually a likely linkage in the risk factors between COVID and obesity as well. So I thought I'd mention that here, even though it's not exactly a hormonal linkage. So moving on, let's talk about cancer treatments. This is, of course, a bird's eye view of something incredibly complex. Not only could you take a whole class on this, you could do a whole specialty in medicine on it. But we are not going to do that, nor hold you to the knowledge level that comes with that. We want sweeping general ideas that you can take with you if you want to do more research into any one particular area. The tricky part with basically all cancer is that it is not a foreign invader. Think about when we talked about antibiotics and we discussed needing to find something different between us and the bacteria to attack with antibiotics. Now we have something that isn't a bacteria. It isn't separated from us by billions of years of evolution, but it's our very own cells turned traitor. So this is a huge problem, because anything that we use to kill cancer, other than simply cutting it out, is by definition going to kill us too. So roughly the strategy becomes find ways to kill off the cancer cells faster than the other cells. This can be through selective delivery to cancer cells using particular mechanisms of the cancer cells, through actual delivery to the cancer cell, or just other tricks. There are definitely some other ones that are specific to certain types of cancer. So for instance, using the fact that certain body parts take up certain types of chemicals, one of the most common ways is to use the fact that cancer cells are dividing very, very quickly. So if you use drugs that attack the replication, you can preferentially attack the cancer cells. Okay, but there's a problem with this too. And that is that although there are many cells in our bodies that don't replicate very quickly, there are many other that do. Now pause and think about what other non-cancerous healthy cells are likely to be affected and how this can affect the person. If you need a hint, you can also work in reverse and think about what side effects come with cancer treatments and therefore what cells are being affected. Come back in a few minutes for some answers. So if we think about our cells that are constantly replicating, we can think about fast-growing things. So our hair, our nails, our skin, and you'll notice that these align with chemotherapy side effects. People going through chemotherapy tend to lose their hair, they get very brittle nails, their skin can become quite unhealthy looking. And then there's one more big one that you may have forgotten about. Let's think about one of the most common side effects of chemo: nausea and other stomach issues. Your stomach lining is constantly being eroded by acid, so it has to replace itself and build itself back up. So this is also replicating very quickly, and this is another area that becomes quite bothered by chemotherapy. There are other avenues of attack as well. They can use drugs that can actually recognize and attack mutant DNA. CRISPR gives us some new possibilities into this area as well, and we'll talk about that / send you to look up some of those when we get to that section of CRISPR. Many cancers use hormones as growth factors. This is why hormone replacement therapy can be a risk factor for certain types of cancer. So if you can block the hormone from being usable to the cancer, you can slow the growth of the cancer, which then gives other drugs times to work. So this doesn't necessarily work as a cure in and of itself, but it can just give the other treatments enough time to actually do something. And there are other drugs which can stimulate the immune system in a way where it can attack the cancer itself. You'll remember from your reading that doctors often combine these drugs into a myriad of different cocktails to treat particular cancers in particular patients. Why do you think they like to use combinations of medicines rather than just larger quantities? So spend some time thinking about this on your own and talking about it with your groups. And if you're still stuck, stop by class and we'll discuss it there for you. But I'm going to go ahead and leave that for your group discussions. I don't have a lot to say on radiation that your readings didn't already say, just that this is, of course, ideally as targeted as possible. Sometimes that targeting is done via very careful beam aiming, and you'll see like they have nettings that actually hold the head in a very particular position to make sure that they're getting exactly the right area and only that area. Sometimes they do it through precise radioactive seed placement, or sometimes even through, in very particular types of cancers that will uptake a certain chemical, they can just put in radioactive versions of that chemical and then it gets preferentially brought into that area. Sometimes they'll do that with thyroid cancers because it picks up iodine. These are sort of the main take-home points from your reading, but I'll leave you to explore your reading for any individual particular areas. Something that science is only now really getting into is the idea of personalized medicine. Previously, to the last couple of years, this largely meant tailoring medicine based on some genetic markers. But this is going to really evolve quickly because more recently this is being delved into by using CRISPR. We'll talk more about that technology later on next week. So let's wrap up this very happy video with an even happier discussion point to talk about with your groups. There's a very scary trend with cancer where alternative medicine alternative medicine practitioners convince patients that their cancer can be cured with so-called alternative treatments. Often these are random herbs. Sometimes it's meditation or yoga and a myriad of other pseudoscientific bull nonsense. I'm obviously doing a rather purposeful job of not hiding my disdain for this. There's no evidence for any of these treatments. At absolute best, they do nothing and allow the cancer to continue on its path. In some cases, it causes very real damage along the way. And regardless of if it does nothing or if it's actively harmful, it costs the patient significant amounts of time. And in cancer, time is everything. I will separate out the yoga and meditation here and say that it might be saying do that instead of the chemo, not in addition. Because, of course, any sort of thing that makes you calmer and more peaceful helps your sense of well-being. But when you start doing it in replacement of chemotherapy is when it's a problem. So for many of us, this situation is actually likely to come up in our life at some point. And while I'm being rather forthright with you guys, and one could even argue maybe a little callous and uncaring in my discussion here, that is absolutely not how I would be talking to a person who actually has cancer. Because cancer is scary, and there is seldom any painless answers. It's a terrible, horrible, awful disease, and empathy is absolutely needed when discussing it with people who have cancer. So this is my question to you. What would you say or do if someone you deeply cared about came to you saying that they wanted to treat their cancer with these unproven alternative, inefficacious treatments, and again, doing it instead of the chemotherapy, not in addition to? So I want you to spend some time thinking about this on your own and discussing it in your groups. And then if you'd like to chat about it, we can do that during class time. Or if you have questions about any of the particular alternative treatments. I will say I'm not super well versed in every single particular treatment. So if you have one that you want to talk about, if you could put that in the Google form for me so I have some time to read up on it. I'm generally just kind of up on the ones that come up most frequently. So we're going to go ahead and end that there. I'm not going to necessarily say anything about that here because I don't think there's one right answer to this. As long as you're doing it with empathy and understanding, you're probably down the right track. But I think talking about this and brainstorming this with groups would be useful. And we can talk more in real time.